You know, I had such a good time chatting with you last time that I didn't even get to look at one of my slides. And so I have a whole big presentation here about the importance of intervention research and why, as communication scholars, that we are particularly in a good spot to do intervention research. And we ended up talking about a lot of the issues too, but I'm always afraid that when I just do kind of a general discussion that there are fine points that I didn't hit. So I thought maybe I would just kind of go through the slides quickly and kind of maybe recap what we talked about. Actually, I think the most exciting thing that we talked about yesterday was your work. I'm really impressed with the kinds of things you're doing, and I'm really excited about the opportunity of working with you. And in fact, already, you know, Icha and I and we're thinking about, you know, ways that we can try and leverage our shared interests and do something really novel and exciting here in Singapore with the HINTS research program. I think that would be fabulous. My dream, you know, even back in the early, I guess it was about 1999, when we first started thinking about the HINTS research. HINTS is the Health Information National Trend Survey. I don't know if you're familiar with it. It's a national survey that the National Cancer Institute has been running for about 20 years.
Yes, finally you're rescheduled.
Well, that's good. I was already missing you.
Yeah.
They started about 10 years ago, and they do it every other year. It's a national survey, representative survey in the U.S. About 7,000 people they survey to try to get a feel for where people get health information, what they know, what they don't know, what campaigns are working and are not working, what they understand, what they're concerned about, what channels they use, all kinds of great information. And then based on those data, public health departments and government agencies around the country develop targeted health promotion programs to try and narrow the information gaps. And it's been a really robust program. Everything in it is open source. We've made everything in it so that it's not just proprietary information for NCI, but any public health department, any private citizen, any scholar. And we also encourage individual scholars to do HINTS research by supporting them, making you know, files available to them with the data, providing coding sheets. We have a full-time statistical consultant that advises people about how to analyze the data. We hold every year data user conferences. In fact, I'm going to miss the one this year because I'm here. But I have my colleague making a couple of presentations for me about the work I've been doing. And it's become a really big thing because, you know, where else for free can you get a nationally representative sample of a validated, tested, you know, robust research program? And it's really great for graduate students in particular and assistant professors, and they want to get their stuff out there. The problem is that when people are doing secondary analysis of the HINTS data, they're really not pushing the envelope very far and not really, you know, making the data go much further than it already did. What they do is they're teasing out the data, they're looking at different combinations of variables, and, which is nice and it's good. But I always really wanted to go beyond the initial survey because there's some limitations with the survey. First of all, the survey is only done in 2 languages, English and Spanish. And that means that all the people in the U.S. who speak other languages are left out. It doesn't really, you know, get at a lot of the really at-risk populations because it's a survey that depends upon a high level of literacy. It ends up reaching people who are better connected, more acculturated. So it really underestimates the disparities in outcomes. It's a national level survey, so it's very difficult to really make good judgments about what to do in small areas. Even though it's geographically matrixed, we don't really have the numbers, for example, to say what's going on in Rhode Island or what's happening in, you know, San Diego, and then do things there, but give some suggestions. And well, that's one of the reasons, you know, this was probably the best thing I ever did was come up with the acronym of HINTS. because it gives us hints as to what's going on. I think that's my claim to fame. And see, I think they all remember me because I'm good with acronyms. I've done this for a number of things, and so that I always wanted to use Hint's research program as kind of a starting point, where then people would take the survey and adapt it for different audiences and employ it in different ways, and maybe push it with more qualitative research so they get more in-depth information. When you're doing a standardized survey, there's only so much information you get, and the HINTS acronym is really one of the problems, and it just kind of gives us a hint as to what people know, but not why that's what they know, or why they don't know other things, or why they're not following up on this, or why they're not using information, or why they're not. One of the big findings we have that's really been interesting is that the vast majority of people surveyed said that they preferred to get health information from their personal physician. And then when later on in the survey we asked where they got their information, the vast majority of people said they were getting their information from the internet. And so why is that? What's going on? They really trust their physician, but it's not easy for them to communicate with them. It's not comfortable, it's expensive, it's cumbersome. The physicians are not available when they need the information. And so we need to figure out how to connect people with their physicians in better ways, and maybe get them more connected via the internet. So that was one of the big implications. But we wanted to go way beyond that and find out what's going on. As I was saying yesterday, when I do intervention research, I really want very rich data to guide the work I do, because I'm really afraid of screwing things up and making things even worse than they were before I came in. And that's not a form of humility on my part, because I've screwed things up in a big way, in many ways over the years, and a lot of public health people have done that. I don't know if you know about the anybody who's ever done any work with Annenberg probably knows about this. The National Youth Anti-Drug program was a huge campaign. It spent millions and millions of dollars. They put together incredible glossy television advertisement. This is your brain on drugs. They had this sizzling eggs, and they showed it for a long time. But they didn't do a really good job of audience analysis research coming in, and they didn't realize that the people who were at greatest risk for abusing drugs were high sensation seekers who were really turned on by the sizzling eggs. And the group that really responded best to those ads were the parents of those kids, who were not really at great risk for abusing these drugs. And so it reinforced the attitudes that the parents already had for not using drugs, and it encouraged the kids who wanted to experiment to use drugs more. And so the more they showed the commercials, the worse the problem became. And what's even worse is that when they learned this, the government, they didn't pull the ads. They let it run for like another 6 months, because they already paid for it. They think, what the heck, we paid for it. Because they just kept making things worse. It was, and this happens a lot. It's not because people are mean-spirited, but we're in a rush to get things out, and we don't always do the work we need. So I was hoping that we could take the HINTS research program to provide a greater sense of evidence and gravitas to health promotion, so that it wasn't just based on good intention, it was based on really good data. And so I pushed early on to provide additional funding through NCI for researchers who wanted to do supplementary HINTS research, that they would take the HINTS research and build upon it in a variety of ways, new methods, new approaches, new audiences, translating the survey into different languages, targeting at-risk populations, expanding it to study healthcare providers as well as consumers. But they never came up with that money. They figured that they invested about $1 million a year in the HINTS program, figured that was enough. So they didn't do that. And so very few researchers have been doing that kind of supplementary research. But I've been doing that. My colleagues and I have been doing HINTS research with different populations for a number of years, and particularly with the Korean Americans and Korean nationals. And and then now with China. And I'd like to, my goal is to try and make HINTS into an international global public health tool. There are very few. And I've spoken with folks at the World Health Organization. They're very, very interested in doing this, but are not willing to spend one dime to make it happen. If I can provide the money to make it happen, they'll work with me on it. I guess they're beleaguered, they don't have a lot of funds. But I'd love to see that kind of a focus, because I think that the health issues are so internationally interconnected. The global issues, the more I get into this, more I realize that we have many of the same issues, the same addictions, the same risk factors, the same problems with early detection, a lot of the same treatment issues. I mean, there are many cultural nuances to it, but I think that if we had some kind of a shared framework, we could work together to promote health and to share resources and share best practices and learn more. In fact, that's one of the really cool things right now about connecting up the Chinese Ministry of Health with the National Cancer Institute. They're two of my major partners in the China research. They had not really been working together before. And now they're meeting together, they're thinking about things, they're sharing ideas. It's really quite exciting. And that's why I think that health promotion can be a form of international diplomacy. In fact, after I leave Singapore, I'm going to Australia, and I'll be working for a month with folks at Macquarie University in Sydney in their Center for Soft Power, which is a new program for promoting international diplomacy through shared human interest. They've been doing it with education, art, music, food, family things, and I'm trying to get them to add health. Health promotion is one of the major soft power functions. Most international relations are based on hard power issues, economics, military, technology. And so I'm hoping that if we can take a more soft power, more humane approach, it would work better, and we'll be able to build stronger relations. I'm not saying that we should give up on the hard power part. I think the soft power is a better sell, and maybe we'll have greater reach. And I really think health is one of the ways of doing that. And if we can build this kind of an international HINTS database, I think it will be a tremendous mechanism for promoting that kind of international diplomacy and cooperation. And then I think the implications from that are really go way beyond health. And they go to promoting better coordination and cooperation, promoting peace, reducing warfare, settling international tensions in a whole range of different ways, promoting cooperation in a range of different manners, promoting greater understanding across cultures and countries. So it's really cool to see that a communication research program has the potential. And right now, it's mostly my dreams of making this work that way, but it has the potential to really make a huge difference across the globe. And I think that we all have this opportunity to make these kinds of the differences. I was really struck by the work that Srivi's been doing, with dialogue and helping people understand each other and build cooperation. I think a lot of times working on that small level like that can mushroom out. And I've tried to do that with social networking in a number of different projects where start off with small things and build it into larger networks of cooperation. All right. Maybe Fran, since you didn't get a chance, we all went around and talked about the projects that we're doing. And the reason I, wasn't that I was, just nosy. Well, I am nosy, but but I like to, maybe use this workshop as an opportunity to provide targeted feedback and suggestions, and maybe even cooperation among us all on different projects. So tell me a little bit about you and the kind of work that you do.
I teach. I'm an instructor in the department. And
What do you teach?
I teach mostly writing modules, and I teach a basic introduction to PR, public relations theories. And I'm personally interested in health communication. I used to be a health and science journalist at the Straits Times. It's the main newspaper.
Oh yes, I've been reading it. It's a good paper.
So when I came in, I have been interested all along, and I currently teach, one of my writing modules is writing for health communication and media. So I'm here actually to just hear what people are doing and how I can make my course a lot more relevant with
I'll have a lot of good stuff for you tomorrow. We're going to be talking about message design and message testing.
Yes, excellent.
There's a really, a lot of big issues with health literacy. One of the areas I'm really concerned about is that most of the health promotion, health education messages we send out are totally unintelligible to the vast majority of people, particularly the ones who most need it. And we're really not utilizing electronic, digital health information systems very well. Where you're basically using them like posters. We're taking like written text and putting them up on the web. And people weren't paying attention to the written text. What makes you think they're going to do it on the web? And not really utilizing the real benefit, communication strength of digital communication. So, so I think there's lots of opportunities to kind of tweak the way we use messages and channels. I'm really a very big believer in multi-message, multi-channel communication, where you use a variety of different processes in concert with one another. Because if people put all their eggs in one basket, and if nobody notices it, it doesn't do any good at all. Plus, I think it's really important to build in reinforcement for messages over time. And then I also really am a big believer in building in interaction. I think interaction is really it's the part of communication that really is exciting, that's dynamic, that gets people involved. And if you don't have much interaction, it's very wooden. And I think most health promotion is very wooden. It's just really dull. And a lot of it is also very negative. Fear appeals and acrimonious. Like, why don't you behave better? Why are you eating what you're eating? Why don't you exercise more? Get the hell off your ass. It's not very nice. Like, I don't want to hear this anymore. Leave me alone. It's really bizarre. So I think it needs to be more engaging and encouraging. Plus, it's distant. A lot of times the people who are telling you what to do are not the folks that you really want to hear from or know very well, and say, what right do you have to tell me, what to eat or what to do or how to behave? And I think that's why we end up wasting a lot of money, not getting a lot done. It's really a shame. I think people, particularly people who are not communication scholars, overestimate their ability to influence behavior. They really believe this. If I tell you to do something, you will do it. I mean, and any of you have had kids, this is not the case at all, That often, I find the opposite. When you tell somebody to do something, it decreases the potential that they will actually do it, because they don't want you to tell them what to do. And, it's a very, you've got to figure out how to be more influential. So we're going to talk a lot about that. So I'm glad to have you, Fred.
Thank you.
Thank you.
It's good to be here.
All right, so let me go through this, see if this works. Intervention research is engaged social scientific inquiry, and I underline the word engaged because I think we should all become more engaged scholars. Not only so we can do more, but we can have more fun. I think being an engaged scholar gives you kind of a juiciness. I love that word, juiciness. Kind of a juiciness to what you're doing, because it's, you've got a purpose, you've got a direction. It's not like you're just kind of putting in your hours, signing in the time clock. You're making a difference in the world. You're contributing. So I love being engaged, and doing intervention research is inherently engaged work. You're addressing important social issues and problems, which means that as communication scholars, we need to be scanning the environment and connecting to people to find out what are the emerging social issues and problems. What kinds of issues are people facing? It also means that we need to get beyond our own comfort zone, our own cultural connections. There's this kind of a weak tie piece to intervention research, is that we tend to communicate with people who are just like us. We speak the same language, we agree with each other, we like each other, it's very nice, it's reinforcing, we feel good about each other, but we learn almost nothing because we know the same kinds of things. So we need to kind of break out of that and connect with people from very different perspectives and different socioeconomic strata, different educational levels, different geographic. That's one of the reasons I love to travel, is because I learn so much more about other people. It takes me out of me and connects me with others. And it also identifies what are the social issues and problems. I'm still really kind of struggling right now and learning about what are the unique social issues and problems in Singapore. Singapore is a really unique place, you know, in many different ways, geographically, culturally, politically, you know, culturally, and so there's a lot of things that I'm learning along the way, but it appears that there's a lot of invisible pieces. That's one of the things, I think one of the things I learned most yesterday about all the invisible behind the scenes issues that are going on here, because there's a lot of focus on promoting a public image, that everything is great. This is a great place, everything's clean, everything's nice, everybody's happy. God damn it, you better be happy here, you know. there's you know, but there's a lot of, you know, I lived in Las Vegas for a couple of years. I was the dean of the Greenspun School of Communication, and you know, there was a lot of effort in Vegas to kind of paint that happy picture. Everything's great here, you know. Last night I went to see the light show by the marina. I felt like I was back in Vegas, you know. It had this kind of a Vegas feel to it, you know, a lot of glitz. But it didn't, you don't realize that there's a lot of populations that are marginalized within that system. And so the people who do it well are put up in the forefront, and the people who are in the background, who are being shafted, are really invisible. And one of the things I really liked about being in Las Vegas is because I could do all kinds of wonderful intervention research and social justice stuff with those populations who are marginalized. And so I think it's learning about those issues. It means that you collect data in real life settings, which sounds obvious, but I think this, you know, is part of our hubris as communication scholars, is that we've been so addicted to sophomore samples and secondary analysis of existing data and archival analysis and content analysis and you know, and looking at ancient texts. You know, I mean, I don't think those are bad things. And we probably learn a lot from them. But it's not that good for intervention research, because in intervention research you got to find out what's going on now, what's happening, what are the issues. You got to get out there. You got to work with people. It's basically a field research activity, and I'm all about field research. I love getting out into the field, meeting people, hearing their stories, seeing what's going on. On the other hand, you got to recognize that this is really messy stuff. There's you know, hard to control what people do out in the field. You have to deal with what's going on. There's all kinds of secular effects. There are you know, issues that you can't control. You know, there are access issues. There are language issues. There are, you know, things that are happening that you have to adjust to. But I think it also provides a dose of reality that really energizes the interventions that you eventually come up with. Everything I do is based on collaboration with public partners. I've learned the hard way that interventions don't work very well if you do them by yourself. It's back to that old thing, and I'm telling you what to do, I'm the expert, and I'm going to tell you what to do, and people will nod and say yes, but inside you're saying, who the hell are you to tell me what to do? And you don't know my issue, and you know, they're raising a million things. Well, you can't do this because of that. You can't do that. That's not the way we do things around here. And when I worked at the National Cancer Institute, we funded a lot of what they called SBIR, Small Business Innovation Research Projects, where we had people develop products and programs. It's very applied research, and they designed these products and programs. And then they went out into the field, and nobody wanted to adopt them because they didn't really match the unique parameters. Like, you know, we've already got contracts with people. There are regulations against this. You know, we can't do it this way. And so lately, we've been trying to push the SBIR people to partner up front with different healthcare delivery systems, different consumer groups, different provider groups, to develop with them the products, so that when they're done, they're adoptable, they're sustainable over time. They were having to develop them in isolation and then go out there, and it wasn't working very well. So collaboration is really a critical piece, and I think as communication scholars we have a unique ability to build those collaborations, because we learn about people. We're asking people about their lives, and we learn how to communicate and speak their languages. You're translating data into active interventions, and this has been a really big problem in communication research. I think in a lot of academic research, a lot of fields, we've been much more interested in finding statistical significance than we are in pragmatic significance. And there's not a lot of reward to going beyond the publication of an article. Once you're done, you're on to the next thing. But I really believe that the really critical piece in our research is taking those data and translating them into programs, practices, policies, documents, tools that people can use. And there's not a lot of reward to that. I think there may be reward down the line if they're very successful. But generally, when you look at promotion and tenure processes, they're not really asking you, what difference your research made. They want to know where you published it and whether it's been cited and those kinds of things. I've been trying to change that in my own program, is to promote what I call public scholarship. People who are scholars that make a difference in the world, and really give them benefits for that. You really need to evaluate the effectiveness of interventions. It's not just doing something and throwing it out there, but also tracking it over time. One of the big things that complicates intervention research is that you're working within living systems that are constantly evolving and changing. And something that seems to be working very well at one point in time may not work very well later on. It's kind of like a relationship, like a marriage. Things that work very well in the marriage at one point, when you were one way, don't always work. You need to kind of shift and change as the relationship changes and people change, and you're always adapting. So the same thing with the interventions. Sustaining interventions is really critical, and that goes back, I think, to the collaboration with public partners, is that I sustain through investing in those partners. They need to own the intervention and take it and run with it. I'm not the right person to do that. I can help them, I can advise them, but it also means that I need to give up control. And a lot of times, it's hard for me to do, because a lot of times I feel like it's my baby. Like right now with the HINTS China research, I feel kind of like a bit adrift because my Chinese colleagues are doing everything. Of course they are. I mean, I can't gather data. I know 2 words in Chinese, ni hao and xie xie. That's it. Gets me very, not very far. And so, but I kind of want to be involved, but I can't. So I'm investing in them, and I'm trusting them to do it. We've done a lot of collaboration up front. Now they're taking it. And the Ministry of Health owns this research. I don't own it. I'm basically just an advisor to them. And I think that's really the right thing to do, even though it may not be comfortable with me. I want to own it. It's better for them to own it, because they're going to use it. They're going to do something with it. If it's my idea, they're not that committed to it. And then promoting future problem solving. I think one of the really cool things about intervention research is not just a one-time, one-shot, one-trick pony, but you're always focusing on the future. Where do we go from here, and how do we build what I call organizational intelligence within the communities that you're working? Organizational intelligence is a term that comes out of Carl Weick's work. Carl Weick developed a model of organizing that I use all the time. I actually wrote my dissertation about 1 million years ago about Carl Weick's model, but it's a model that really resonates with me. And he talks about how we use communication to develop intelligence for guiding future action, so we don't always have to reinvent the wheel. And I think as intervention researchers, what we're doing is we're trying to build intellectual capacity for the audiences that we're working with, so that they know more, that when the same problem happens again, or a similar problem, they're not starting from step one. They have an advantage, and they have some rules to utilize to help solve those problems. At the very least, they have a better understanding of what the issues are. Many times I find in intervention research that the biggest issue that's blocking dealing with the problem is a failure to fully conceptualize what the problem is. That a lot of times, for example, for years I worked with hospitals with turnover of nursing staff. There's a big issue in the U.S. I don't know if it's an issue here or not. It's still a big issue in the U.S. because it's a high burnout job. And as soon as you train people and you get them to know what's going on, they're running away from the profession. They're trying to do something else because it's, burning them out. And so they were conceptualizing this problem as a recruitment issue. And what we need to do is recruit more nurses, and the more they recruited, the more people were leaving. It was kind of a bad problem. Eventually, we realized what the problem was a retention issue. What do you do to keep nurses on the job? How do you preserve the organizational intelligence that they have? And once you think about it in a different way, you conceptualize it, it changes everything. Because these hospitals were putting tons of money and effort into giving out bonuses, doing recruitment fairs, stealing nurses from rival hospitals. It was a crazy situation because the more they did it, the more successful they were at recruitment, the worse the problem became. And I think many times we find that once you gather more data and you understand what's going on, you recognize that there's a different set of issues. White says that there's this notion called requisite variety. Requisite variety is a principle that says that you need to respond to a problem with the same level of complexity that's in the problem itself. But we have a tendency oftentimes to kind of gloss problems over. And instead of really solving the problem, we kind of put Band-Aids on them. And so, but if it's a really big problem, for example, you've got an infection, Band-Aiding is not going to solve the problem. The infection is getting worse, you're going to have a fever, you got to get to the root of what the problem is. So he says to do that, you really need to kind of address the issue with the same level of complexity that there's there itself. And as intervention researchers, what I'm trying to do is kind of unpack what the nature of the problem is so we can come up with strategies that match appropriately, that resolve those problems and reduce the problems piece by piece over time. Yeah, I like this picture. I stole this from somebody somewhere along the way because it's basically saying that intervention research deals with a wide variety of people in real situations. The key issue is that you want to promote societal adaptation. So what you want to do is you want to help people adapt to problems. You want to help them become smarter about adjusting. Basically, it's a form of what they call socio-cultural evolution. If we depend on biological evolution, it takes a long time. We're all dead. That's what happened to the dinosaurs. They didn't last very long. If they only could have figured out, let's build fire. Let's that's what they call societal, socio-cultural adaptation. And so what we want to do is help people be smarter so that they can manipulate their environment. They can overcome the issues. Right now, for example, we're facing huge challenges with climate change around the world. And we've probably gotten to a point now where we're not able to really stop climate change. I think at this point we need to start thinking about what do we do to adapt to it and how are we going to adjust to it, what kinds of remedies. And some of those will be technical, some of them will be educational. We're going to have to change maybe the way we utilize different resources, the way we live. But because we're crafty and we know how to do this kind of adaptation, I'm confident, I'm optimistic that we're going to be able to survive. But if we were not able to do that kind of adaptation, this kind of a challenge would wipe us all out. We'll wait and see what happens. I tend to be an optimist, but maybe we won't be able to do that. We'll see. Communication processes provide access to relevant information. So all of my research, all of the interventions are based on information. I basically have an information-based model. I believe that information is the most valuable resource that people have in life, and particularly in health and health promotion. That if you have access to relevant information, you can make good decisions about promoting your health, about getting the best care, about helping others, about adapting to challenges, about promoting personal well-being, about dealing with all kinds of issues. The problem is that not only do we not always have access to relevant information, we often have the wrong information. And that's really a bad, it's a problem to be ignorant, but it's even more of a problem to have bad information and really desperately believe it's right. For example, the vaccine controversies. There's a large population of people who adamantly believe that vaccines are the devil. that vaccines are killing children and killing people and are really bad and are discouraging people from getting vaccinated. We're seeing this, rebirth of polio around the world because people are saying that, the polio vaccine is going to cause all kinds of irreparable harm. They don't remember how bad polio was. And so we're seeing a reoccurrence. TB is coming back because people are not getting vaccinated. So it's not just, providing people with information, it's encouraging them to see more clearly what the real issues are. So you need to increase understanding with interventions by reducing uncertainty. You try to enable informed decision making. So these are the things I try to do with my interventions. I try to figure out what different courses of action people can take that work within their situation, within their culture, within their community, within their socioeconomic. I mean, one of the big problems we've had with health promotion is we recommend things to people that they can't do, or that's not easy for them to do. Buy all this equipment, you have no resources for doing that. Go out and, join a gym, and there's no gyms in the area, eat certain foods that are not available easily or you don't know how to cook with. It's just, I think we need to come up with courses of action that make sense. And a lot of that is fueled by the background research that you do in this work. Identify potential partners and collaborators. Establish guidelines for future actions rules by retaining organizational intelligence and promote collaboration. I repeat that one a lot because it's really a critical one. Strategic messages. And so this is where we were talking with Fran earlier about message design. We need to come up with messages that really resonate with people. That first of all, I think one of the biggest problems with health promotion is that there's very limited exposure to messages, that people are not paying attention. Sometimes we're so bombarded with messages that we just don't, and then the messages don't appear to be particularly salient or interesting or exciting or engaging, or the people who are providing them are not sources that we really want to hear from, or the channels that are being used are not really good. So I think we need to kind of come up with strategic communication strategies for communicating effectively with others so you can inform them, enable identification of similar goals, influence beliefs and behaviors, build meaningful relationships. And I think that's really one of the biggest pieces that's missing from a lot of health promotion interventions, is that we see everything on kind of an individual level instead of looking at it as a community, because the social norms within communities are so powerful. If you can influence a social norm, for example, with the Korean Americans, one of the things we're doing, we're getting ready for our intervention phase now, is we're working with a lot of religious organizations. There's a very tight religious community within the Korean American community, and we've been working with the ministers to change the way they do things, like change the foods that they serve at their different communal events, and to do different activities that promote, screening. It's through those relationships, rather than just saying you do it, is that we have the group doing it together. Encourage coordination, promote learning, adaptation, and social organization. So communication inquiry can inform the use of interaction to identify serious threats. So I think these are the things when I do interventions I want to accomplish. I want to increase people's ability to identify what the health threats are, to seek relevant health information, to share information with others, particularly within their families and within their social networks, provide needed decision-making support. More often than not in healthcare, people are not making active decisions, they're just allowing others to make decisions for them. And I'm finding, particularly in a lot of the international work I'm doing, it's even more the case where there's not a strong sense of consumerism in healthcare. I find that, for example, in Japan and in China, that consumers don't like to ask questions of their doctors. They don't ever disagree. They don't ever say, I don't really want to do that, I want to do this. Whatever the doctor tells them is what they do, and that's often not the right thing for them. Because the doctors don't, not the doctors want to hurt them, but they don't understand their situation. So I want people to make good decisions and to be more assertive. We want to test implementation of new programs. We want to establish responsive new policies and practices. We want to promote adoption of best interventions and then sustain them over time. So I think that communication scholars have some opportunities to examine how strategic communication can achieve key societal goals like health promotion, environmental protection, shared governance, education, and promoting social justice. And I think that, you know, this is basically only a few of the things that we can do, but it covers a tremendous amount of ground. So while the work I do is primarily focused on health promotion, I think that the goals of communication intervention research are much broader. That, you know, we can focus it on family issues, on education issues, on political issues, on economic issues, on environmental issues. You know, there's a very broad purview for what we can do. So in terms of my own work, you know, I figured that it'd be good to kind of, you know, rather than, you know, pushing you, is to say this is what I've been doing. I try to find the best ways to help people seek information, deliver information, primarily the healthcare system, identify health needs and ways to avoid risks, provide health education and support, promote adoption of healthy behaviors, establish health information policies, practices, and tools, and manage effective healthcare systems. It's not an easy thing to do all these things, but these are some of the goals. And so I think these are things that communication scholars are actually pretty well positioned to do, better positioned in many ways than many of the people who work within the healthcare system, because we understand the communication dynamics of doing all these things. You know, these are really major health care, health promotion activities, and every one of them is communication based. And I don't think people in the healthcare system often recognize that they are professional communicators. I encounter this a lot of times with physicians. Physicians say, yeah, this is really nice. I'd love to do this, but my job is to deliver care. You know, I don't communicate. That's not my job. And I say, well, how do you deliver care? Well, you know, I find out what people's problems. How do you find out? What do you do? Well, you got to ask them questions. That's communication. And then when you want to deal with the problems, what do you do? Well, I give them treatments. How do you get them to follow through? I have to tell them what to do. Well, that's communication. And so, you know, if you want to accomplish your job, even though you might have a tremendous amount of medical knowledge, your ability to communicate is the thing that allows you to be effective. So you better be a really good communicator. And things are starting to change, I think, in medical education, where there's much more focus on the effectiveness of communication. Unfortunately, I'm finding that it's not really communication scholars who are generally doing the training about communication. A lot of times it's psychiatrists. I'm not sure why that is, because I figure that they understand communication. Sometimes they do, sometimes they don't. They understand abnormal communication. Communication influences the entire continuum of healthcare. And this is a standard model of the continuum of care. It starts with primary and secondary prevention. Primary prevention is where you stop diseases from happening at all, usually through behavior change or avoiding carcinogens and clean drinking water, all those kinds of things. Secondary prevention is where you try and detect early, so you can treat. You don't really prevent them, and you kind of prevent it from getting worse. Early detection, diagnosis, treatment, survivorship, end of life. There's a huge primary central communication component to each of these pieces. And so a lot of times when I'm doing my work, I'm focusing on one or more. And a lot of times there's a lack of recognition about how communication operates in all those areas. And a lot of times I find, maybe it's because of my unique communication-based perspective, but I find that a lot of times the breakdowns in the quality of care and health problems are based on breakdowns in communication. The lack of recognition, the lack of utilization of appropriate messages or effective channels or reinforcement over time, or breakdown in relationships. Communication is needed to deliver relevant health information. And we talked about this earlier. I think relevant health information is the most critical tool that people have in healthcare, not just consumers, but also providers, also policymakers, also administrators. So a lot of what I do is to try to glean the most relevant, powerful information and the sources of those information, and then make it available to those audiences in ways that they can understand, in ways that they can utilize, so it's usable and effective for them. And often it's developing tools. And one of the things I'm really excited about digital technology is that I think that we can come up with some very exciting digital tools to supplement the traditional communications. What happens in healthcare is that we depend a lot on one-on-one, one-time communication. The doctor says this, it goes right over somebody's head. Maybe they understand at the moment they get home, they don't remember what they said. They don't, oftentimes they never understand, but they're embarrassed to say that they don't understand. I've seen lots of situations where the doctor provides information, says, "Do you understand?" And what does the patient say? "Yes." And then the doctor leaves the room, and the patient says, "What the heck did he say? I have no idea what's going on." Often we give information to people when they're in a state of shock, right after they've gotten a serious diagnosis. They're not in a situation where they can understand. So we need to find ways to supplement that with other information. And I think that we can give handouts. We can also provide information online, which I think is really great through smartphones, through where people can get it whenever they need the information to back it up. Relevant health information is a prerequisite to active participation in healthcare and health promotion. And we know there's a large body of research that suggests that the more actively involved people are, the better their health outcomes are. Health issues are complex, and relevant information is needed to reduce uncertainty, provide rationale for action, facilitate cooperation, empower taking charge and being involved, provide direction for providing care, and influence new practices and policies. So, here we are with health communication. It's really kind of bizarre if you compare health communication to some of the health professions like medicine and some of the biological and psychological and psychiatric. We're really a very young, very immature discipline. We've really only been around for about 30 years. And we're still coming up with our theories and methods. Even though we have kind of a long rhetorical history, we have a lot we need to catch up on to be able to work with these people. And one of the things I try to do is to be humble and not realize they don't have all the answers, but try to do data collection, really in-depth data collection, to find out. So I utilize multi-methodological approaches. I don't think you necessarily have to do that, but that's been my modus operandi, because I find that each method has its individual strengths. And often I find out that different methods kind of nest together. For example, I might do start off, I often will start off with in-depth personal interviews with cultural informants. Like I'll find key people within communities who know a lot, or have an axe to bear, or angry about something, or frustrated, or been, and a lot of times health advocates are like this, and you basically ask them what's going on and what the problems are, and they will dump a ton of good information. You learn a lot really quickly, and you do that with a bunch of people. And then based on that information, I know enough maybe to put together a survey, because I really didn't have enough information up front to be able to do that. And I almost always will use field experimental research for evaluation, because it's really good at identifying what differences have been made. So I'm always tipping. I also like to do archival analysis, where I look at documents, because it's a non-reactive form of data collection where you can, because people have a lot of personal involvement in healthcare, they may not always tell you the truth. And so it's good to have some other more verifiable data. I like to have hard data for health outcomes. So often I'll use data from medical records or utilization data. For example, I've been doing a lot of research on medication adherence. And you'll ask people whether they take their medication and say, oh yeah. And then you check the medical prescription records, and they haven't filled their prescription for about 5 years. But they say they take it because they don't want to be bad. They don't want people to yell at them. So those kinds of data, and then you can track that data over time. I love using archival data as baseline data. When you start off, you have some information about what the current status is, how many people are being treated for this, what kind of outcomes do they have, what are their vital signs, what kinds of medications are they taking. And then you can track that, and you can do your intervention, and you go back and you look at some of the same things, see if you've moved the needle on any of them. And that's a really powerful. In fact, it's one of the things that I think is most influential with healthcare systems, because they want to see that you're making a difference in terms of actual biological and health outcomes. I find that there's a lot of resistance to satisfaction data. Communication scholars, we love beliefs, values, attitudes, and we do a lot of how well do you like the system? Do you like communicating with your doctor? Well, lo and behold, a lot of the doctors don't care if the patients don't like them. They care if they're getting better. They care if they're coming back. They care if they're paying their bills. And so those kinds of data are really powerful. The economic data I found, unfortunately, is often the most meaningful. I always do an economic analysis of what difference this makes, how much it reduces costs, how much money does it save, and then that's often very powerful in terms of adoption. I typically will integrate both human and mediated communication. One of the things I'm not really happy about field is that we've been trying to, not connect all the different channels that we have. Journalism programs that do this, and media programs do that, and computer, mediated communication programs do this, and interpersonal communication programs, and I see it all kind of working together, nesting together, and so my work often will combine. I think there's a difference between healthcare and health promotion. The healthcare system generally is more focused on healthcare, which is a more reactive approach. It's important, but it's always better to prevent disease than it is to react effectively. Even the best treatments have very negative outcomes, are painful, are time-consuming, are debilitating. So I really think that we need to kind of put more resources in health promotion. And health promotion is basically a communication process. That's basically the only way you can do health promotion is to get the word out and let people know and influence their behaviors. I want to improve outcomes. I also want to develop and refine existing programs and practices. So part of what we need to do is to get a handle on what are the existing delivery, communication, promotion programs and practices. Right now I'm starting a new research program with the Veterans Administration. We're looking at discharge planning. I don't know if you know what that is. Discharge planning is when they educate patients after they've been in the hospital, after they've had a procedure, and they send them home. Basically what they want them to do is to follow a treatment regimen so that they recover from surgery and they don't end up back in the hospital. But they're finding in the VA that there's not a lot of compliance with the discharge planning regulations, and the patients end up getting sick, getting infections, and they're back in the hospital. And so what I want to do is figure out why this system is breaking down. So I'm at a point now in this research at the very beginning where I'm doing interviews, and I'm also doing observational research where I'm finding out what are they doing, what is the process for patient education during discharge planning, who does that, where do they get the information, what do they say, how do they do it, how comfortable are they with it, how well do the providers like it, how well do the patients like it, what tools are they using, what systems do they use, what technologies are available. And so once I do all that kind of a basic analysis, I can build a picture of what's working, what's not. And then we can start developing interventions to improve upon it. But if I don't really understand those existing practices, there's no way for me to change it to improve it. And a lot of times it's a very time-consuming process to gather all the background data. So I want to focus on examining strategic messages, influencing meanings and beliefs, disseminating health information, informing decision-making, promoting social influence and behavior change, identifying new and better channels to reach audiences, building in feedback systems and interaction. I find that one of the biggest problems in healthcare is that there are not enough feedback systems, so that when people don't understand it, they don't know where to go. So they just learn to live with uncertainty. And the uncertainty can be very problematic because they don't know what to do, and sometimes they just don't do anything at all. And sometimes they make big bad mistakes. So I want to build feedback systems so people have places where they can ask and they can figure out what's going on. We know that feedback is probably the primary mechanism for reducing uncertainty. But it's amazing how often we don't have a lot of feedback systems. And I don't think it's just healthcare, but I think in education too. When you're teaching your students and they don't understand, how easy is it for them to get feedback, and how responsive are instructors to receiving feedback? You know, are they encouraging students to ask questions, or are they driving to get through the damn lecture? You know, move on. You know, no questions right now. I'm busy. You know, well, how do you know whether people are getting it or not? And then building better relationships, both within the healthcare system, interprofessional relationships. And it's amazing to me, the more I work within healthcare systems, how fragile and dysfunctional a lot of interprofessional relationships are between different medical specialty areas, between different departments, between administrators and providers, between doctors and nurses, between aides, I mean, there's a lot of acrimony within the healthcare system, and there's a lot of suspicion. And there's also a lot of intercultural issues where different disciplines think they have the corner on knowledge, and these other guys are really missing the boat. And that becomes a big issue. And then the relationships between consumers and providers, and then the relationships between consumers and their social support networks. Also relationships between peers. I'm really very big on promoting peer communication in healthcare, support groups, online health information systems, advocacy groups, I think are really powerful, and we need to promote those kinds of communities to support health communication. All right, so I think I've said some of these things already. I'm dealing with issues like access to care and health information, quality of care. There's a lot of problems with how do I say this? Mistakes that are made in healthcare. And some of the mistakes are really tragic mistakes, like giving people the wrong medication, wheeling people in for operations they were not supposed to be getting, removing the wrong limb, you know, things that are not easily solved later on. You know, it's kind of, and medical errors become a really big problem. Often the medical errors are communication problems. Adherence with therapy has become a really big issue. And I'm actually moving away from the adherence stuff. You know, we used to start with compliance, which I thought was really kind of, you know, top heavy. You know, you will comply. You know, this is, and then we moved to adherence, where people would follow directions. But I think that we need to focus more on informed decision making, because sometimes people may have a good reason not to want to take a medication or follow a recommendation. But I think that it's the good reason part that's really the critical factor here. Are people not following because they don't know what to do, because they're afraid of it, because they don't have confidence, because, you know, they don't know what else to do? or are they making that decision because they have good reasons for it? So I think we need to provide better decision-making support. Adopting and maintaining healthy behaviors long-term, minimizing pain and suffering has become a really big issue. I don't know how familiar you are with the term palliative care, but palliative care is not been very well embraced in Western medicine. In fact, it seems to me that a lot of Western medicine moves the other way. It makes people very uncomfortable and causes pain and suffering. If you think about cancer care in particular, you know, I imagine that in 20 years from now we'll look back on chemotherapy and we'll say, you did that to people? What, are you crazy? You know, you killed off all of their good cells so you get a couple bad ones? People are going to think of that like the way we think about using leeches, you know. It doesn't make any sense. And we're developing more targeted therapies. But I think that we need to have greater concern for promoting comfort in care throughout the entire process. The way palliative care is being conceptualized now is that it's basically seen as end-of-life care for people who are dying. So they don't suffer very much. And mostly it's a pharmaceutical approach that, that we use pharmacological agents to dim the pain. But I think that there's a huge communication dimension to making people more comfortable, helping them be more in control, providing social support when needed. That's really important. And I think it should be throughout the entire continuum of care. That we should be making the healthcare system easier to deal with, more comfortable to access, less invasive, less embarrassing, less painful. A lot of people don't go back to the doctor or follow recommendations because they've had such a bad experience. They just feel humiliated by that system. Provision of social support. A lot of the interventions I develop are basically support prevention. How do you provide people with relevant information about key issues from people who have insights into those issues that provide support to them where they need it, when they need it, in ways that they can understand. And then coordination of care, which is also a huge communication issue. Just making sense of what's going on. There are a lot of patients in the VA system, for example. They have an older population that they're serving, the Veterans Administration, that have a tremendous number of comorbidities. They're being treated for stress disorders, heart disease, diabetes, paralysis, and they're seeing 10, 12 different doctors. They have all kinds of different therapies, and nobody's coordinating any of that care, and they can't keep track of it all. And so how do you communicate? How do you get members of the team to share information? Sometimes we find out that one provider is prescribing medication that counteracts the medication that another provider, or that there's an interaction effect that makes things worse, and nobody's aware of it. All right. So these are some of the things that are my guidelines that I try to accomplish. I'm not sure if I'm always doing this, but these are the golden rules that I try to live by. I want to make sure that everything I do is theoretically grounded and guided. And I have a number of different theories that I use. I often will use a diffusion of innovation model. I often use Weich's model of organizing, health belief model, stages of change. Do you know about the trans-theoretical model? Readiness for change. I have a couple of my own models I've developed about relational communication competence and health outcomes, which I've been using a lot. A lot of people have been adopting it. It basically says that the better we are at building meaningful information, relationships in healthcare, the better our outcomes are. And so a lot of times I try and figure out where those relationships are breaking down so that people get the information and support they need. And this has actually been verified with a lot of studies that actually has been confirmed.
What's it called again?
Relational communication competence and health outcomes. The RCC Yeah, I'll send you some references. Actually, there's a new encyclopedia of health communication that Terry Thompson is editing, and there's going to be a special entry for that month. I try to conduct valid, reliable, rigorous communication research. I think one of the long-term complaints within the discipline has been for applied research that people sort of being quick and dirty, that you were just kind of like, you know, helping people in a very superficial way. But I try to make sure that the methods I use are very strong. And I not only do that so I can back myself up and get my work published, but also to make sure that I'm not making major mistakes. I try to work with real audiences as much as possible. I can't understand how you can do intervention research in any other way. Utilize complementary methods. I collaborate with key stakeholders, both internally within the healthcare system and externally. I try to do longitudinal research because I recognize things change and it takes a while to sustain. I try to do translational research, research that will make sense for guiding policies and practices. And then I try to work with people in the community to build systems, structures, agreements, programs, new departments, new policies, new legislation, so that things can be sustained over time. And this is kind of a new thing for communication scholars, but in a lot of ways I end up doing things like congressional briefings where I meet with members of Congress about new laws, helping to write new legislation, work with lobbyists, work with people in accrediting organizations that come up with new regulations for education, for licensing, to make sure that things happen. And I think it's really important to have those kinds of connections to make sure that your work actually gets implemented. Because what ends up happening with a lot of communication research, even a good applied research, is that it gets published and it gets up on a shelf and nobody uses it. And that's one of the frustrations I had when I worked at the NIH, is that we were funding all this research and it really wasn't making such a big difference in terms of the way healthcare was being delivered. All right, my most effective interventions were designed to be strategic and evidence-based, interesting and involving. That may sound really simple, but it's not, because, you know, a lot of our own research sounds really interesting to us. Try explaining to somebody who's a layperson what you're doing. See them, their eyes glaze over, you know. Oh yeah, especially a couple, complicated jargon terms, you know. Start talking about statistical analysis, methodological issues, appropriate for intended audiences, adaptive to changing situations, consistent and reinforcing across multiple messages and channels, and sustainable. Build community participative approaches, careful needs and audience analysis, and we'll talk a little bit about that in a minute. Gathers data from real consumers and providers, involved subjects in data collection and interpretation. I think you need to do this really early on. I find that I have a predisposition to certain tools, certain outcomes that may be more based on my understanding than the community's understanding. I really need to kind of withhold my judgment and let people guide me in the community. For example, I found that when I work in China, I had all these ideas about what they should do, which was really stupid because I had no understanding of what their system was and how people deliver care. And I really made a dope of myself several times. I said, "How about this?" They said, "No, we don't do that here. This is, that's not the way things work." And so I learned to be more, careful about hearing what people's ideas were and supporting them. Designing user-generating interventions where the, often when I gather data, I will have kind of a feedback session with community members or my informants to see what their take on those data are and what they think it means and how they want to use it. Often I will do, after a survey, I'll hold some focus groups to unpackage the results. And I'll often ask people, well, how would you solve this problem? What could be done? We'll try to do some creative problem solving with people who are actually part of that community. Share implementation with your target audience. Work with constituents to identify opportunities for refining and sustaining key policies. Often I'll find that people in the community may have access to resources for implementation and sustaining interventions that I don't have. And certainly I don't want to be continuing to fund this work. What happens in a lot of projects, funded projects, is that there's a lot of excitement when the research team comes in with resources to do something, but when the resources dry up, the program dries up. And so I think one of the things to do is to try to figure out what kind of slack resources are available within the community and who are people who already have authority over these kinds of issues, who you can give control to and find ways of implementing the program. For example, with the, earlier I was talking about the nurse turnover research. One of the things we did was in a big urban hospital, there was a big program in nurse recruitment. They had about 10 staff members, they had a big budget, they were traveling all over the country, they were advertising. We basically encouraged the hospital to change the nurse recruitment office into a nurse retention office. And then we changed the job description of the people there to focus not so much on recruiting, but on keeping nurses happy. And developing programs, we built in new roles and activities for nursing staff to provide feedback and to develop programs. We had a new set of committees that changed the whole system. So what we did was basically we used existing resources in different ways. And by changing that, it became part of the system. And they didn't need me anymore to do it. In fact, one of my research assistants was eventually hired to run the nurse retention program or to be one of the key people in there. And so I had some influence, but I didn't have control over it. All right, dissemination. This is a really interesting one. I think it's a really pertinent one for us to think about, is because dissemination to most communication scholars means getting your work published in a refereed journal that only you and about 5 other people like you will read, if we're lucky. And so I think we need to think about other strategies for dissemination. I'm not saying don't publish. I'm a real big believer in publication, and I publish a lot. And it's been a really important part of my career to get information out. But I try to publish in a variety of different venues, not only academic venues, not only in communication journals, not only in academic journals. I think that getting your work out covered in newspapers is really important. I often will publish in newsletters within organizations that I'm working with. I think that getting my mother's goal for me is to be on the Oprah Winfrey show or one of those shows. She'll think that I've made success, and I think that's really good. If you can get that kind of coverage, I think that would really becoming really a public scholar in many ways. I think we've got to think about ways to disseminate broadly. The other thing is to get your partners involved and to work with them, help them disseminate through their channels. I think speaking at a variety of venues, I give lots and lots and lots of talks to different groups and different organizations to get information out. It's also a great way for me to meet different people and build partnerships and to connect with folks. So, but I think we need to take dissemination very seriously. So I think that we need to have evidence-based information to disseminate. We need to report our results to multiple audiences. We need to generate media coverage, and one of the things I teach about is media advocacy. How do people generate buzz and get media to cover the things without having to pay for it? how do you get advertised without having to pay any advertising money? It's one of the really clever things that communication scholars know how to do. And then conduct and report continuing evaluation over time. I discourage you from waiting until the end of your intervention study to publish your work, because first of all, it takes a long time, and you may never finish. So what I do is I do incremental reports. Like when I do my basic audience analysis, I just agreed this morning to work with a scholar in the States on a new program of research for promoting gay and lesbian health in the U.S. through the use of digital media. And so I'm basically going to be a mentor to this guy who's got his own research program. And so I'm thinking about what I want to do. So the first thing I want to do is tell him to do a big analysis of what the problems are, and he needs to write an article. We'll write an article together about what are the health issues that are facing gays and lesbians, and why is it a relevant issue? What are the communication dynamics? So that's one piece. The next piece is to analyze why are digital tools appropriate for this audience, and what's going on already, which is another one. Then we'll maybe do some data collection. We'll learn more about the audience and their preferences and the kinds of problems they have, and we'll write that. That'll be another piece. And then maybe we'll start, and so every piece along the way becomes a different point for dissemination. It also becomes a way for you of documenting your progress in doing your research, because your colleagues and your bosses want to know what you're doing, and it also provides a track record for when you want to get a grant. You can cite the work that you're doing and demonstrate that you've got previous research. Pilot data are always very convincing for grants. Involve key policymakers and leaders, which I've talked about a little bit already. Means you need to figure out who those people are. In fact, yesterday I was talking to each other about who are the people who would benefit from a hence Singapore research program, and what office would want to control that and fund it. And let's find those people, meet them, and convince them that this is a great thing that can help them achieve their goals. I mean, basically that's what happened with the Ministry of Health in China. We met the guy who was in charge of health education, and this project filled a need that he had, and so he provided the resources to do that. But without making that connection, without having that relationship, I would be spinning my wheels. I would never be able to do it. I can fund it, plus I wouldn't have access. And so I think that if we can find the right partners and policymakers, it'll make things happen. And then empower community members to share relevant research results and implications. Let them be heroes. One of the things that I try to do is to my community partners, either in public health departments or hospitals, I allow them to be leaders in this research, and then feel a sense of ownership. Let them brag about it, and be interviewed about it, and get awards for their work. We had a conference, the DC Health Communication Conference, last March, and the theme, we had a pre-conference on promoting global health, and I invited all the folks from China, from the Ministry of Health and Renmin University, and we gave them awards for their work, and they went back to China, and they had press, and they had, it was a really big deal. We did a memorandum of understanding between my university, Renmin University, the Ministry of Health, and the National Cancer Institute that got a lot of press, and it was a way of letting everybody along that chain from all four institutions earn a little bit of honor along the way. And I think by doing that, you kind of encourage a sense of ownership, you encourage a sense of pride in the program, and you encourage people to expend more effort to support that research. And then you're not doing it all by yourself. All right, global applications, and we talked about this already. I think that there's tremendous opportunity not only to work locally. I try to do this in kind of a hierarchical fashion. I always start off at the community level, because that's where it all happens. The kind of a small community level, and then it builds into a larger, maybe within an urban area or a region, and then maybe a national, and then eventually to an international and a global focus. But I think that when you do this kind of work, that you need to have the mindset that what you're doing, even if it starts at a very small level, has the potential to influence things on a larger level, because the issues that you're dealing with are not idiosyncratic just to that issue. Issues of late stage diagnosis for breast cancer are not just a problem in Malaysia. I mean, that's an issue that's going on in India, that's a problem that's going on in in the US, that's a problem that's going on in Europe. And I think that you can apply what you find in that work to a variety of different settings. All right, this is my final slide for this one. Oh, this was a long one. This is a model that the Canadian Cancer Society put out about ways to reduce the cancer burden through a variety of different research activities. And I really like this model. I don't think it does it all, but it hits a lot of the good stuff. It basically values a variety of different research approaches. The people who do basic fundamental research, biological processes, communication theories, they're often very threatened by intervention research because they don't want to do it. It's more hassle than they want to do, and also they feel like it devalues what they're doing. So here it says, okay, this fundamental research is really great. This is where you build the theories. But if you just do that, how do you know whether the theories work? So then from here, maybe you'll develop some interventions based on those theories and test it out and see whether or not you can confirm that work and whether it makes sense. And then you'll do surveillance research to basically track, basically like epidemiological research, to see what's going on and to track whether or not things are happening. And then you do kind of a synthesis between that to build application and program delivery recommendations. And that's how you can reduce the cancer burden and promote health. So, while I'm talking about intervention research in this workshop, I'm not saying that it's disconnected from fundamental and surveillance research, but it's all part of a larger process. Oh, I guess this is my last one. This is the big send-off slide. I want to develop an infrastructure for rapid advances in knowledge about health communication. I want to test new strategies, models, and tools. I want to disseminate research results to relevant audiences. I want to implement best communication practices, discovery, development, and delivery. That was a mantra that Andy von Eschenbach, who was the former director of the National Cancer Institute and then became commissioner of the FDA, came up with. It's probably the best thing he ever did. It's a discovery. He was also the guy who said that within 10 years we were going to end cancer, death, and suffering. I remember when he made that proclamation, all the people that were working in the National Cancer said, we're going to do what? Anyhow, discovery, development, and delivery. Discovering new ideas, developing programs, and then learning how to deliver them. I think that's really the essence of intervention research. I think that if by doing this we can really make big differences. And what I'm hoping will happen is that this will encourage you to do that kind of work. So, sorry about that long slideshow. Yeah, I probably could have cut out about 5 or 6 of them. They all are, meaningful to me. We love all of our children, Let me open it up for you and see if there are questions, comments, reactions, things that you thought about as we went through this process.
To answer your question about thinking about it is, on Thursday morning, I'm going to the School of Public Health, who has started public health communication module for our undergrads. But, their syllabus is entirely health communication. So Mohan and I recently had a battle. And so they have invited me to start off their semester and talk about, the importance of health communication. And most of the things that they're talking about in message testing, designing, new media, social marketing, promotion. I mean, everything is campaigns, different aspects of health comm. And so I was, writing all of these notes down.
Who's going to be teaching it?
So I'm going to take a few of their lectures. Mohan will take a few of their lectures, and then they have industry people coming in, mostly from government agencies, to talk about perhaps a more application of intervention and research. But I think we're covering the theoretical parts. Not that I'm most ideal, because I have my own health comm module that I teach, so I'm overlapping over there. But some of the things that you were saying there, as I was thinking in terms of impressing upon, most of them are science students, public health students, maybe few from arts and social science. So they've gone over to public health to talk about health communication, right? So it's really, I was thinking, some of the slides that you have and some of the key points of kind of taking it out and stealing. I'm sorry, I'm going to steal some of your wordings and kind of the importance of health communication, because I think the idea from public health is really health communication, or communication is just a tool, right? It's anybody can do it. So a lot of things that they're teaching is, we have an entire theory or model or courses around those ideas and concepts, but yet it's sort of thrown in there like, oh, this is what we can do. So I have been thinking all week about strategy in terms of what it is that we would want these students to promote, and I think perhaps the application part, the connection to intervention, but really some of the things that you said about not only testing, but really the last point of discovery also, right? And really coming to the point of where communication is central. And I really like the continuum. And really, because it's a public health medical kind of a perspective, and saying, well, look, we are there all the time in everything that you do. It's not like it's secondary, but central. And I think I'm thinking at this stage of Thursday morning, that's one thing I want them to really walk out of there, or set their tone for the semester, really. The idea that we are in every stage of that continuum, every part of healthcare, everything. It's not just that, anybody can do it. It really is, you have to put thought into it. There's planning, there's really this intentional, way of doing it. It's just not an afterthought, right? Where you think, communication.
Public health is really interesting field. I wrote an article with my friend Ed Mayback a couple of years ago in the Journal of Communication about communication and public health as overlapping, synergistic fields. And I'll send you a copy of it. There's some really nice similarities in the fields, and there's some real big differences too. And so in many ways we can be very complementary to one another. The fact that the public health people do really good longitudinal, epidemiological research. They're really good at tracking over time. And communication scholars don't do very good longitudinal research because we don't have the resources. We don't have the attention span, I think. We're just going to get it done on the next thing, And so they're really good at doing those kinds of surveys. But we're really good at doing more kind of experimental work, and we have some really interesting strategies for providing data that evaluates outcomes. And so in many ways we complement each other methodologically, theoretically. I'll try and send you that article before you go over there on Thursday, because I think this is a great opportunity. Schools of public health have embraced health communication in a very big way. In fact, I speak at a lot of schools of public health around the country about health communication. I work with them. The best schools of public health, Johns Hopkins, Harvard,
the School of
North Carolina and Chapel Hill.
The School of Public Health here used to have, so that article would really help, I think.
Public health communication is very much health promotion focused. They leave out almost all of the healthcare communication part. which is really kind of sad. There's, a couple years ago, I edited a 5-volume set for SAGE called Benchmarks in Health Communication, and each volume had a different area. One was communication and delivery of care. They don't do that in public health. The other one was communication and health promotion. That's what they do. Another one was on e-health. They're starting to do e-health. Another one was on health information, healthcare systems and delivery of care, the way that health systems use like electronic health records, the organization of the healthcare system. And then there was another one I can't remember right now. Oh, health risk communication, on the 5 areas. And I think that's a really interesting way of breaking it down, seeing which ones they cover, which ones they don't. I think that we can collaborate with schools of public health. They become really good partners. Often they're better connected. It appears to me, I don't know this real well, but from what I've seen, this university is very healthcare focused. Huge medical enterprise here. My God, the hospital is gigantic. There's all kinds of, so I think ways of connecting this department to the medical enterprise is going to provide tremendous resources and opportunities and a laboratory for doing research. And I'll bet those folks over there know the people in the Singapore Public Health Program Department, of the officials.
They get a lot of money from the government. Part of the funding for the School of Public Health, I mean, they actually have a research arm that's connected to the ministry.
In fact, I think you should try and get a joint appointment. I think you should see if you and others in the department can get a joint appointment between public health and communication. Since you're already going to be teaching for them, it would be kind of a way of kind of making you an insider. It's one of the tricks I've used a lot with different agencies I work with. I get them to appoint me as one of their, and then I get access to internal money from them, and I trade at different things, and I help them to make decisions. I learn about opportunities before anybody else, and I think you can do the same thing here. That'll be really good. I think this is a great thing. Don't worry. You sound like you were worried that they're like stepping on your toes.
No, well, it started with, they asked me can you come be a guest lecturer in our public health communication class? Sure. Can you take 8? And I said, the semester is 13 weeks and I cannot be a guest lecturer for 8 weeks. And so then I said,
so now we can say, well, maybe you can give me an appointment.
Yeah, so I didn't think of that. That's why.
And then maybe they can reduce one of the courses you teach here.
So we ended up negotiating. I would do few and Mohan would do few, but I hadn't thought about that. But that's a great thought in terms
You've
of.
You've got a foot in the door. This is an opportunity.
Yeah, because they do have all the money.
Yeah, sometimes things that look like a constraint often become an opportunity. But I like that, and I think that connecting with the medical health enterprise here at this university, given the infrastructure, is a really great thing to do. Mohan told me that there's some interest in the medical school about providing training programs for physicians, communication training programs. But he doesn't know if he has the resources to do that. And I said, well, then why don't you get some resources from them? I bet they have tremendous resources over there. And then, have them kick in some other goodies along the way, travel money, and equipment, and, titles, whatever it is you want, you figure out what kinds of, your wish list is, and make it happen. I think it also makes, a lot of times in universities, communication is not seen as one of the line departments. This is not like the main enterprise. In fact, in a lot of universities, like many of the Ivy Leagues, they don't even have communication departments. They're kind of buried in psychology or somewhere else.
The ag school.
Right, the ag school. Although they've done a pretty good job at Cornell at making it work, the risk communication really resonated with the ag school. But I think that if we can, make that work, make communication seem to be more of a central piece, that's really, really good strategy.
Well, Gary, that was one thing that was very helpful for me, to see the role of communication in healthcare very clearly. I think that was a question that Leanne asked yesterday. When you think of the holistic picture of health, where does communication fit in, and these are very helpful for us to be confident about our contributions as communication scholars, and to be able to say these are specifically the ways in which we can contribute to that research. And the other thing which struck me was that this need not be just having this overview. It was not necessarily only for health communications. If I'm interested in media literacy, so I was looking at it continuously from that lens. Who are the partners that I need to have? Who are the people who would benefit from media literacy? So if it's concerned parents, if it's educators in schools, then I need to connect with those groups, and I need to think of ways in which I'm doing media literacy effectiveness research in the lab, but I need to work with real audiences to take it to schools or to take it to organizations, family-centered organizations and forums, and then see how it works. What are the people within families, within schools, within community organizations? What are their problems that they're facing? What are the real issues, and how do we come up with solutions which are as complex as the problems themselves? And the interconnectedness, the holistic picture of what a research program should look like, that clarity that you have is so helpful, because it gives me a sense of I'm always focused in this particular project, in this particular study, but I see that I should connect it with a whole range of a system of research, and not just research, but also think of scholarship more broadly, and think about it in terms of making a real difference in the world, and then how can we make that happen? And in the process, there will be publications, and that will happen. But for someone like me, who is an idealist and who's very committed to social change, then the starting point has to be from that space of analyzing the audience, and then building partnerships, and then delivering solutions which are based on dialogues, and then tracking its effectiveness, and then figuring out a way for it to be sustainable, not just in health, but whatever it is that one is committed to. That clarity I was able to get from this presentation.
I made my entire trip worthwhile. Thank you.
Yeah, I think that's what I was thinking too, right, in terms of going to School of Public Health as students, that kind of clarity in terms of really showing or understanding this is not only the importance of communication, but where and how it becomes important, and therefore centrality of it in that whole process.
And this will be very welcome. This approach in public health is a very applied field. Mm-hmm. If anything, it's not nearly as rigorous and theoretically grounded as we are, because they're really focused on making things better, promoting public health. But if they don't have a very strong grounding and methodological footing, they end up spinning the wheels a lot. That's one of the problems in public health, is that it's not always very effective. They have a hard time getting things done, and a lot of the health promotion tools are not very good. It's kind of like, what I was telling you about the FDA, saying, let's do these graphic warning labels, without really realizing that actually might make things worse. So.
Gary, I was just thinking to myself, you were talking about 30 years for this field, and looking at your stuff, obviously it's so comprehensive, and it's really nice to see all of the bits and pieces that have, and how the field has grown in terms of, you having things on engagement and organizational intelligence, and, working with things like understanding, sustainability, and not just sort of one shot. And it's, it's very, very comprehensive, and I think it's really, really great. I still think that lots and lots of people, especially in public health, don't don't get the comprehensiveness and the sort of the interconnections, and really, because you were saying that, I think it is so very true that information is really, this is an information model, and information is really, really valuable, and I think that works for a lot of people. But even in the stuff that you're talking about in terms of people who know what they should do, but there are various, I can't get that fruit and vegetable here, I can't access that person or that, that system here, I can't, I can't force my John to wear condoms, whatever. So there are structural issues, and I think that most people, while you've worked that into the considerations in this very comprehensive model, I think that people in public health and the rest of that, I think that they still just want to, we've got the message, and it's just about how many, the breadth of the people that we can capture. And without a lot of these theoretical understandings, in the 30 years that you can track in your model that you've arrived at. So that's the problem, and I think, that we still have, and I wish that there was one, or at least a set of international, approach, or that we had, that we really got people to understand the, like you said, the requisite variety of the complexity of the issue.
I think the fact that we're having more dialogue across disciplines with people in public health, and more collaborations, and also more really good communication scholars like Doug Story and Rajiv Rumal and my friend Vish at Harvard, who are bringing communication theory to these places. I think that's really great, and it's going to change things in many ways. It's going to make their work more sophisticated, and it's going to make our work more applicable. They're really good at implementation, and we're not. And we're really good at big picture theory and methods, and they're not. And so we have something to say to each other.
I don't think they, in terms of diffusion of innovation, in terms of people being information rich, people get information. Who gets the information? People who have access to information. The gap increases. I mean, I don't think people are thinking about that, like in any kind of real sort of sophisticated way. So, yeah. I'm encouraged, and I wish that people would, I wish that we were doing this in public health in a lot more
We'll see what develops out of this. I think maybe we'll develop into maybe more collaborative. Maybe we'll have meetings together. Maybe you'll end up doing classes where, our students in communication and their students will work together. At my university, I've been sending my graduate students out to teach courses in health communication in the health education department, and we're having a wider span of influence, and then we're doing collaborations, research collaborations with those folks.
One of the things that so far we haven't talked about research collaboration, but one of the things in terms of curriculum is that we have gotten some of our health comm, and we don't have that many health comm classes because we're growing this area onto their course listing, so the students they can come here and take it this is for their master's program, so they can take our health comm classes, and it's an elective for them that's counted as opposed to an optional, because the students here, the way it is, they have limited number of coursework that they take as a system. It's not like early years where you take courses after courses in 4 years, multiple lessons.
Yeah, I don't know what the kind of the reward system here is, but in my university, it's all based on student numbers. And all our funding is based on, if we have enough people registered for our classes, our budgets are approved. If we're under a target number, we get punished. And so when we can get students from other disciplines to take our classes, that's a really great thing. Because then we have extra money, we have more merit pay, so everybody's happy.
Yeah, especially because our graduate pool is quite small compared to most graduate programs in the U.S. We have a huge undergraduate population. Graduate program is quite small, and partly because of the funding. So it's great to be able to have And other students also bring in that diversity and perspective. I think for our own students, when you have a discussion and they go, oh, but gee, in public health, this is what we do. And I go, yeah, but as health, even to have them have that discussion, and say, but in health communication, this is what we've been talking about.
There's some interesting organizations that I've become involved in that are very interdisciplinary. You know, early on in my career, I did, ICA and NCA and regional. But now I'm involved in the American Academy for Health Behavior, which is represents a range of different disciplines in the Society for Behavioral Medicine, which is very interdisciplinary. So communication becomes a really interesting partner in those groups. The Society for Participative Medicine is one that I've become really involved with. And so I think I encourage you to look at some of those other organizations. They become really good umbrellas for focusing interdisciplinary collaborative research.
Kerry, is there any society for preventive care? Because one thing which really resonated with me in the presentation was that we need to think of ways to prevent. And also when you talked about comfort and palliative care as an overview, not just end-of-life issue, that was something that really touched my heart. And I feel that that's something that we should keep in the forefront of providing healthcare. And then we should go beyond the sense of healthcare systems, existing healthcare systems, when you think of health and wellness. And for instance, I mean, I'm just saying this from a personal experience that when I read the Yoga Sutras, which is an ancient text on yogas, it talks about 2 sentences about physical health, and then 194 sentences about holistic health. It talks about 1 sentence about disease and 195 verses about wellness and prevention. So the disease-centric approach and also only looking at hospitals or clinics when we're talking about health and wellness is a very narrow perspective. And prevention, and I think stress is a very key thing that cuts across all of these. You talked about comorbidities, right? I feel that there's something about the lifestyle that we live that has to be changed, even when you talk about climate change, right? So, not as a response, but also something that from childhood we have to inculcate some of these principles so that we are not putting bandages on these at a later point of time. Because if you're sensitive to your body, you know that disease is coming up, right? So how do we sensitize people to listen to their own bodies, and how do we sensitize health providers to listen to the patients talking about their own situations? These are all some things that, for me, those are issues that still need to be funded, still need to be researched in terms of stress reduction, and how do we promote health literacy and healthy behaviors from childhood, and also about how to integrate, like I was saying yesterday, alternative and traditional medicine with the excellent abilities of Western medicines for diagnosis and all of the technology that exists. How do we take the best of both worlds and bring them together is something that I'm very committed to, and I would like to kind of start seeing the people who are also committed to this same idea and having conversations with them to think about ways in which to bring about this change.
Yeah, I think you bring up some really good issues. The American Academy for Health Behavior and the Society for Behavioral Medicine are both very much focused on prevention, because they're trying to influence behaviors. They're influencing, smoking and dietary and exercise and mental health issues. In terms of palliative care, is both an international and a American organization, IPOS, the International Psychosocial Oncology Society, IPOS, and the American APOS, American Psychosocial. They do a lot of work on social support, on wellness, and on palliative care. I've actually been presented several papers at those conferences about communication approaches to reducing pain and suffering.
Just to back off of that, I mean, I was really kind of fascinated in your direction going with this, the soft, was it the soft diplomacy? Because it starts to, for me, rather than focusing on the individual, and I love the change from health to wellness, but I think of it in terms of, you know, the controversy of public health, which measures success by sort of individual measurements in a community. You know, we've been able to change whatever, reduce hospital stays, bed stays per whatever, you know, and thinking, now I think we're colliding with the social change stuff where, like you're talking about, you know, I guess what I got from your presentation was talking about the organizational intelligence, you know, in communities that, or if you want to call it empowerment in the kind of the social change world. Now to start thinking about how these people not only are sort of passive, you know, patients, but now starting to voice what things, and we may be going into economic realms, and we may be going into other realms of holistic wellness beyond sort of, you know, body fat indicators or whatever else. And so, you know, health and social change are starting in sort of a much more broader kind of a view of it. So I'm really encouraged by that.
It's really cool how the physiological and the psychological meld together. I mean, you're talking about, you know, the focus on wellness. I think that our personal health has a lot to do with our perceptions of ourselves. And, you know, there are people who have serious disease who feel very good and live very productive lives, and then there are people who have minor health problems who are totally debilitated, can't get out of bed, and so it has a lot to do. It's not a disease issue as much as it is our ability to cope, and I find that communication becomes a really critical factor in promoting this sense of wellness and empowerment and, you know, assertiveness and. You know, there's been a big discussion on the Society for Participant Medicine is a very active online world. I've been following a whole litany of messages. There's a breast cancer patient in New York who's had very serious breast cancer for a number of years, and is at Memorial Sloan Kettering, and she sent more than 1,000 tweets out over the years, and has an ongoing blog about her experience, and has been sharing information, very personal information about every part of her treatment, and doing that has been very empowering for her and provided her with a sense of purpose. And then recently there was an article that was written in the New York Times about her that was not very complimentary. Basically, portrayed her as a whiner, you know. And then all these other people in the society were so angry at the people who wrote that negative article about her, because they've been so empowered by this woman's work, and were so respectful of her ability to share that information, and see that it's helped so many people. Actually, it's been very interesting to see that, but it shows you the power of her communication and the ability for people to identify with what she's going through and to share that information. But, you know, it's very complicated. I love the idea you said, Srivi, about not just focusing on clinics and hospitals, because most healthcare and health promotion happens at home. You know, I think the family, we should be looking at, in many ways, I think health communication is a form of family communication. Yes. My colleague, Carla Fisher, studies mother-daughter communication about breast cancer. It's our focus area. And so she's been really focusing on family dynamics and family communication. And lately, one of my doctoral students, her husband has prostate cancer. And so we've been talking about maybe studying the ways that fathers and sons would communicate about prostate cancer. They don't.
Yes, it's a short article. Have you had any success? You said that the economic data are really powerful in helping you to sort of make your case. Have you had success sort of giving these measures of related to school truancy or any sort of social things outside of sort of, you know?
Well, there's been a number of success areas. One of them was I did a lot of work with the Veterans Administration in an area called care coordination. I began working with them about 15 years ago, and we were introducing little technology boxes called health buddies in the homes of veterans who were getting chemotherapy. They were having a lot of problems with these veterans getting out of control. They only wanted to see the doctor like once every 3 months, and they'd send them home, and they'd get into big problems, and so they wanted to get feedback on their condition. And so this health buddy would basically provide some physiological and self-report measures every day from these patients and their caregivers about what was going on, whether they were sleeping, whether they were having pain, and then there were some basic measures of heart rate and temperature and other things. And automatically those data were being checked and filed, and when patients' charting was out of the norm, it would trigger a nurse to call them and say, what's going on? I see that, you know, you're having this problem. And they were able to keep the patients healthy, plus they were able to provide advice to the family caregiver, just do this and do that, and then fix this infection, or help them with that. And it ended up reducing mortality dramatically. It reduced morbidity. It reduced emergency care utilization. It reduced the strain on the healthcare system, and it ended up saving the VA millions of dollars. And this was just in a test in one region of the country. They loved the data so much that they made this program national, because there was basically strong economic data, and it was just the fact that we were able to track that. But we had great satisfaction data. The patients loved it. They didn't care. they liked the fact they were saving money and reducing the strain on the healthcare system. So I think that collecting those data can be very powerful. And I think that there probably are ways of tracking it. The fact is that we need to get a handle on what are the critical baseline measures and how can we collect those data over time. One of the advantages we have now with the electronic medical record is that there's a really nice source of data that are available if we can disentangle it from the identity of people, so we can maintain anonymity. I think there's a really great way of tracking changes over time, because there's all these regular readings. Recently, with the work I've been doing, I've got another project I'm doing with the VA about end-of-life counseling for advanced cardiac care patients. There's been a problem in the VA that the cardiologists don't want to admit that their patients are dying, partly because they don't want to feel like they're not able to save them, and partly because they don't want to have to deal with them talking about dying and death. So it's causing a real big problem, because patients are dying without any preparation. They don't end up getting entry into hospice when they need it. Families are surprised. It's a big issue. So we developed a system that would track on the electronic medical record a number of physiological indicators that would suggest which patients were likely to die. And it automatically generates that information, and it alerts the cardiologist and everybody else on the team that these are the patients that need attention, that need communication. And now we're designing programs to train the cardiologists and the patients to communicate effectively about end-of-life issues. But they can't avoid it anymore because there's that hard data.
I wonder if that would be information that you would want as a patient. Would you want that information as a patient? Like your score, I'm a 6 on the...
I don't know. I think that the key thing here is to let the patient decide whether they want it or not. I think that's been the guideline for end-of-life communication, is to let the patient set the guideline for what they want to know, what they don't want to know. All right. I'm gonna, this was the PowerPoint from yesterday.
Oh.
I haven't gotten to the PowerPoint for today, so I'm gonna see if I can load that one up. Probably one of the things I've learned that's been most critically important to enabling me to be effective interventionist is to learn that I can't do it all by myself. There's this kind of a notion that if you work hard and you're smart and you try, you can do things, but in the real world, nobody does anything by themselves. It's all based on relationships. And so the critical factor is figuring out who the members of the communities are, who are the communities that you need to work with, and how can you get them on your side, and how can you learn from them. At Mason, I direct the Center for Health and Risk Communication. It's an applied research center. We do a lot of intervention research. And it's all based on promoting adaptation to health threats and risks, increasing well-being, and this relates back to its review saying both physical and psychological, enhancing resilience and social justice within communities, consumer empowerment and participation so that people can be more in control and promote their own health. So I'm not just promoting their health, but I'm giving them the tools to promote their own health. And providing information for informed health decision making. And then I want to promote consumer-provider collaboration. And then I ultimately want to reduce health disparities.
Is this the center at your university or?
Yeah. This is the organization that I created about 5 years ago. And everything we do is based on collaboration, and that participation. We work with a lot of federal agencies. Not only seeking funding from these agencies, although that's really a critical piece, but also with being partners with them and helping them achieve their goals. And so I often will speak at meetings that these agencies put on. I'm on advisory boards for these agencies. I serve on review groups for these agencies. I have them, members of the agencies, come and speak to my classes and meet with me, and then we work on collaborative projects together. I find that doing that provides me with kind of a new set of opportunities that I learn what new issues and priorities and concerns the agencies have way ahead of time. Not so much so I can just do whatever they want, but to see where we have shared interests. And also I have an opportunity to shift their priorities and influence what they're doing so that maybe I can convince them to buy into what my priorities are. So I can tell them that I'm really interested in palliative care and there's not much going on in this area. What are you doing here? And talk to them about it and plant some seeds. And before long, there may be a program announcement in that area, or there may be a new focus, or we maybe do some project together. I do a lot of different things with these groups. I have formal affiliations with NIH, FDA, and I don't even have VA up there. I get that Department of Defense. I have memorandum of agreement with the Department of Defense where we do collaborative research in a lot of the military medical centers. I helped HRSA develop an online training program in cultural competency and health literacy that they've been using with tens of thousands of providers around the world, which gives me reach that I never would have by myself. I do a training for the CDC. My colleagues and I, we go to Atlanta and sometimes to West Virginia where NIOSH is located. NIOSH is National Institute of Occupational Safety and Health. It's a division of CDC. And do training programs on message design, campaign design, evaluation research, health literacy, social marketing, media advocacy. We have a list of about 25 different programs we do, and we do a number of them every year. My faculty like it because they get extra money. We worked out a really nice deal where they get an honorarium of $2,000 a day for 1, 2, and 3 day
Oh.
workshops. That's on top of the regular salary. So even in a couple of years when we didn't get big raises, everybody who's working with me was making extra money doing these. All their expenses are paid. Plus they get to do training with a lot of the active decision makers and health promotion people at CDC who end up wanting to work with them and ask them to be advisors and give them grants and contracts. And so it opens up a lot of things for us. So that's been a really good way for us to get things done. And it's a particularly good thing for my center because we're in the DC area and we have all these agencies there. But that's been really good. We also work with local governments on a very small scale. One of my biggest partners is the Fairfax County Public Health Department, which is not a very big organization. They maybe have 20 people that work there, but they have a pretty big purview. It's about 1 million people in that county, and it's very diverse, and they have a number of different issues, and they often have access to block grant money from the CDC and other places, and they often will want me to help them, so I get grant money from them. When I apply for grants, I also have community partners who are working with me that gives me credibility and also access to populations that I normally wouldn't have. And in fact, we created a local organization, community-based collaborative that I help run called the Fairfax County Health Literacy Initiative. And it's comprised of my center, the Public Health Department, public schools, the libraries, a number of other government agencies, senior care centers in the area, recreation centers, a number of nonprofits, so about 15 different organizations. So we meet every 6 weeks or so and basically talk about what kinds of issues and problems we're facing, what kinds of needs we have, and how can we work together. And we've gone after grant money together, we've done a lot of projects together, and some of them have ramped up to larger programs. The latest one we did was a local community campaign for immunization called Community Immunity. It was based on promoting flu vaccine, primarily among college students who didn't think they needed it. They thought, they were young and healthy, but they didn't realize that when they were not getting immunized, they were putting at risk a lot of other people in the community who were more vulnerable, like elderly and children, because there's a herd level thing that you have to have a certain number of people immunized. And they didn't realize that they actually were at risk, and we put together a video of some of my graduate students becoming movie stars, talking about their problems they've had with the flu. And so, and I think that campaign we may end up trying to do on a larger level. Foreign governments, and I've been doing more and more work with a number of different governments, and I now have friends, colleagues, collaborators who are officials in these different countries, and I'm hoping I'll do the same thing in Singapore. Not only is it a wonderful thing for providing opportunities for new projects, and also helping me ramp up things that I've done at the local level to a global level, it also provides me with opportunities for free international travel, and I get to meet different people and have a lot of junkets and have fun and enrich my understanding of the world and have new partners. And I think that there's tremendous opportunity to do that kind of work. I also work with a lot of nonprofits, non-governmental organizations, the Robert Wood Johnson Foundation, Kaiser Family Foundation, National Minority AIDS Council, Entertainment Industries Councils, National Park and Recreation Association, Sun Safety Association. Couldn't fit that all, so I have all those acronyms up there, and a lot more. There's a ton of them out there, and they become really good partners because they have a lot of expertise in their own area, and they have their own connections. For example, I did a big project with the National Park and Recreation Association, where they had developed rebuilt an urban park in a very poor inner city community in DC, where the local park had become known as Needle Park because all the junkies were hanging out there, and they were gangs, and people in the community wouldn't send their kids out, and so they had worked with some other community organizations and some recreational equipment manufacturers and local government, and they got some money and we cleaned up the park, worked with the community, found out what they wanted, built a really beautiful park, chased the criminal element out of there, reclaimed the community, changed the entire culture of that the community, and then they asked me to evaluate the program. So we did a lot of really interesting observational research and experimental testing and comparison with similar communities, and demonstrated that making that kind of environmental change actually had changed the entire community, changed health behavior, changed attitude, changed community pride, changed health orientation, changed nutritional practices. It was amazing how kind of a basic physical change in environment changed everything. But the bigger thing was the fact that they were working with the community and used this project as a way of empowering members of the community to take charge. And so that provided me with opportunities and also connected me to a number of other
What
organizations.
was the name of the project?
What do we call it? Marvin Gaye Park. Marvin Gaye, I don't know if you know Marvin Gaye, the singer with the high voice. He grew up in that neighborhood, in Anacostia region of Washington, D.C., very poor area, 99% African American, almost everybody in poverty level.
Is there like a case study of that?
Yes, I published everything. Yeah, we published it in Health Education Research. I'll send you the, and I think I've got the book that Mohan and I just did on health disparities. I think there's a case study in there about this project. So that's another thing. I publish my things in multiple places. That's how you get a lot of publications. You make one article work in 5 days. International health agencies, I work with a number of them. I'm working with the World Health Organization for about maybe 6 or 7 years, and they bring me to Geneva quite often, and I also send me to other parts of the world to do projects. I've been working with UNICEF for a couple of years now, and I have a couple colleagues now who are working with UNICEF, and I advise them. And that also provides me with a lot of interesting opportunities. I work with a lot of different media organizations, and I think it's really important for us to make those connections, not only because they have access to information, but it's a wonderful way to disseminate our findings. And if you have partners there, you can disseminate without incurring any cost, because you'll be feeding them with information. And then I work with a number of different healthcare systems, both hospitals, clinics, HMOs, and that's always expanding. And then lately I've been working with the enemy. I'm working with the pharmaceutical industry. I'm working with the Coca-Cola has become my latest benefactor, which is really strange because I'm not a very big fan of their products. Although they tell me they're one of the largest fresh water producers. They do lots of juices, healthy juices. And what do you think? Something Coca-Cola?
Yeah, I think that's Coca-Cola.
But this is actually tap water because the bottle is
This is
from our kitchen.
The truth of the matter is they make all their money from the regular Coke.
Yes.
Also with technology corporations. This network of collaborations opens up many opportunities for me to do interesting work and to get funding, and also have social influence. And I think it's really important to build those kinds of networks. It doesn't happen immediately, but over time it's a social networking activity. One of the things I see as our mission is to promote civic engagement and service learning through research teams. I talked about the National Park and Recreation Association project. I've been doing adherence research with Merck for about 5 years now, and they've given me a lot of money. And I also work with Merck researchers who are really top-notch and they do everything in a really big way. We wanted to do some message testing. They connected us to Lewis Harris, and we had thousands of people that we were testing our messages with. We would do message testing at the university with 50 people. We thought that was hot stuff. we had like national, and and so they provided us with opportunities to do things. They set us up with a collaboration with a CVS, Caremark, where we were able to do dissemination of our tools to millions of people. It just provides you with interesting opportunities, and these organizations are very outcome oriented. They really want to make things happen. GALA is an organization that I started with my friend Paula Kim a couple years ago, called the Global Advocacy Leadership Academy. We've been doing products to promote health advocacy around the world. And then the project in China has been really an active collaboration between 4 and maybe 5 partners. My research center, the Center for Public Opinion Research at Renmin University, the Ministry of Health in China, the National Cancer Institute, and also the CDC China has become involved in our project as well. I think working in these kinds of teams provides a tremendous array of benefits. Some of them intellectual, is that they know stuff that I don't know. I mean, there's a lot of stuff that I don't know, but they know lots of things, particularly about their communities, their people, the way their environment is set up, the unique constraints and opportunities, their connections, their tools, their Slack resources. So we can do things that there's no way that I could do it myself. I mean, I could not have done built that park, there's no way I could do that, but NPRA had that capacity to do that. And also I think that we have something to share for each other. So I like working in these teams. When you're looking for funding, there's been a focus, particularly by the NIH and also the NSF, and I've gotten funding from both of those organizations for what they call transdisciplinary research teams. And that's been a relatively new thing. They want people from representing different fields, different disciplines, different backgrounds. And when you do these kinds of connections, you've got that built in. Internships is I start off by sending students to these organizations, and then many of them started getting hired by them, and now I have my own network of my inside mafia within these organizations. My friends and family are there, and they owe me money, and I'd say about half or more of my doctoral students end up working for organizations like this. The other half go into academia, and sometimes they move back and forth between it. But it provides me with an interesting network. Lately, we've been sending faculty for internships. My colleague Xiaotran Zhao, who I work with on a lot of projects, is now doing a year-long internship with the FDA, with their Center for Tobacco Products. And Xiaotran's learning all kinds of new things and getting lined up for different kinds of funding, and it'll be great. So, early on, I was leading all of our projects, and he was my co-investigator. Before long, he's going to be the PI, and I'll be his co-investigator, and that'll be cool. That'll be really great. And so I think using these as kind of networking for education and also for building opportunities is great. Training programs, CDC University is the program that we use. They think they call it CDC University for Public Health Communication. This all happened when my friend Jay Bernhardt was the director of the National Center for Marketing and Communication. Sorry, Marketing and Media, I think it was called. And he's no longer there. He's at Florida. But when he started it maintained over time. Anova is the big hospital chain in Northern Virginia. That says they have like 6 big hospitals and all kinds of clinics. They basically have a monopoly on healthcare, and they have world-renowned cardiac centers. They're building right now what their hope will be an NCAA designated cancer center. They hired the former director of the National Cancer Institute, John Niederhuber, to become the director of their cancer center. And so working with them and doing training for them connects me to all those physicians, and a number of my colleagues are doing collaborative research projects with physicians who we trained. Through the GALA program, we do all kinds of training, the Global Advocacy Leadership Academy. And then we have ongoing programs with the Department of Defense. And this has been really interesting because I'm an old peacenik. I never thought I'd be working with the Department of Defense. But I'm working with generals and admirals, and we do train. We bring in regularly, like once every semester, a group of top-level military brass to do programs with them on issues like intercultural communication, and international communication, and media communication, and strategic communication. And because we do that, we started a program where top-level rising officers, mostly like people who are majors getting ready to be promoted to colonel, they want them to get master's degrees, and they send them to our program, our master's program, to get a degree in strategic communication. They take them off active duty for a year and a half. They pay all their expenses and their tuition. They buy all their books. They move on them and their families to Washington, D.C. for that time, and they dedicate all their time to studying. And so we have every semester about 10 or 12 top-level officers, many of them who have been stationed all over the world. Some of them have been in active combat, some of them pilots. We have from the Air Force, the Marines, and the Navy. They become, after a year and a half, become alums of our program. And then they go, most of them go back to the Pentagon where they're stationed. And one of our alums is now the Deputy Director of the National Center for Information Security or something like that, which is huge. It's basically the agency that collaborates all the information agencies in the U.S. And so, in fact, I nominated him this year for alumni of the Graduate Alumni of the Year Award. And so we have connections with those folks, and which provides us with other research opportunities and influence. Plus, if we can influence these people maybe to communicate more effectively, maybe we'll avert World War III, you know, or at least improve outcomes. And so I feel really good about that. We do a lot of dissemination activities through a variety of publications, media, presentations. We're on a number of different speaker lists, and so we do workshops around to get information out, not only about the issues, but also about the center and about the work that we're doing. We have a number of different community coalitions that we work with. Fairfax County Health Literacy Initiative I talked about, and the National Minority AIDS Council is another one that we work with. We do a number of conferences. We're working with a group called the Links Incorporated, which is a kind of a women's professional service organization for African American women. It's a national organization in the U.S. and they have a very big Northern Virginia coalition, and they put on health summits in collaboration with us every year. They're primarily for African American leaders, community leaders, to help them learn about different health issues and then bring that information out to their communities. And then I have a lot of my students will speak at those meetings, and we'll bring in health professionals and deal with a range of different issues, from mental health to cancer to obesity to diabetes to a whole range of health issues. And then we do the DC Health Communication Conference. I don't know if you know about this, but we do them every other year. You probably know about the Kentucky Health Communication Conference. They did this for a number of years. They do it every other year. I always thought it would be a great idea to do an alternate conference in tandem. They do it in even years. We do ours in odd years. And so we did 2009. No, 2011 was the first one. 2013, and the next one will be 2015. And we bring a lot of interesting people to our campus. They get to know what we're doing. And we also promote a collaboration. It's a small conference, where we usually have about 100 people. and we do very interactive, and we promote a lot of collaboration. The first conference, I brought a number of program officers from federal agencies for a pre-conference so they could talk about their program priorities, and then have individual meetings, one-on-one with people about grants, which was great. A lot of people ended up getting funding out of that. And then we have a lot of panels on different issues. We have different themes for the conference. So that's been a really great way of disseminating. Plus, it's a way for me to kind of talk about the projects that I'm working on. And then we will do a number of community projects. For example, we did we did the largest unveiling of the AIDS quilt at any university in the world on World AIDS Day 2 years ago. We brought lots of people in, brought a lot of awareness. We ended up doing free testing for more than 100 people. We had a lot of community organizations that work with HIV and AIDS, including my research partners, but others. And then we brought in people from other area universities and healthcare systems as a way of kind of promoting awareness. We're probably going to try to do something about mental health as well. We do a lot of collaborative research projects that are designed to develop infrastructure for advancing knowledge. It sounds similar to my previous one. Train the next generation of health scholars. Test new health promotion strategies and tools. Disseminate results to relevant audiences. Implement best practices to improve outcomes. Build sustainable community partnerships. You've heard this one before. Discovery, development, and delivery. So that's been kind of the guideline for how we use community partnerships to achieve our goals. I find that community partnerships are something that everybody can agree is good, but not everybody is willing to put in the time and effort to make work. I think it takes a little bit of courage to connect with people outside of your familiar environment. It's hard for people to kind of cold, connect with somebody and, hi, I'm Gary, I'd like to work with you, that kind of thing. Like, who are you? What do you want from us? I think that the best way of doing this is through kind of a social networking process of trying to identify people who know other people, or when you meet people in other situations, is to follow up on it and to talk with them about areas of shared interest and set up meetings and do lunches and give talks and invite people to campus, and to build those collaborations. Part of it, I think, is maybe a little bit of work to try to identify who are the key people, who are the stakeholders that you want to connect with. And there are stakeholders on a lot of different levels. One of the stakeholders are the groups that you want to influence. For example, let's say you want to do health promotion to promote better screening for colorectal cancer. So who are the groups that are at risk? Who are the people you want to influence? And who are the people who are not getting the screening they needed because they have negative outcomes? So you need to do some research and figure that out. And then figure out who are the people that you can connect to who are involved in that issue. Who are the people who are offering the screening? Who are the people who have their job is to promote that screening? If they learn that you're interested in helping them accomplish their goals, they'll be really interested in working with you because you're making their life easier. Are there any community organizations that are focused on this issue? Are there any colorectal cancer support groups or advocacy groups? And figure out who those people are and get to meet them. Are there any government agencies that are in charge of doing this work? Are there local agencies? Are there local healthcare systems where they're doing that work? Are there policymakers who have a vested interest in this issue? A lot of times, if you can identify a legislator, like in the US, a congressperson, senator or congressperson who has a family member, or they themselves have a certain health problem, they're often very interested in supporting that issue. And I found in a lot of the work I do a lot of work related to different cancers, that cancer is in many ways a kind of nonpartisan issue. It doesn't matter if they're a Republican or a Democrat or any other political affiliation, that this is their issue and they're touched by this. they become very interested. And then once you made those connections, you can get those folks to introduce you to other influential legislators. I've been doing a lot of congressional briefings over the last 5 or 6 years, where I go to Congress and I meet not so much with members of Congress, but usually their staff, and they come to these briefings. But a lot of the, amazingly, a lot of the decisions that the legislators make are made based on their staff. The staff do all the groundwork and they brief them and tell them what are the important positions and get things done. And then I've been trying to place a number of my students, graduate students, in these legislative offices as well and make those connections. So I think that figuring out who the key community people are and then working with them can have tremendous benefits. But it does take some courage to reach out to them and then to build relationships. And so just as I think that in healthcare, building good relationships allows you to achieve good outcomes, I think in doing community-based research, the relationship is where it all begins as well. On the other hand, there's a lot of time and energy that it takes to maintain and nurture those relationships. But I think that there's a lot of benefit as well. I don't know if any of you have done a lot of community partnerships. I'd like to hear about your experience, or if there are community partnerships that you've been thinking about doing. What's your experience? How many of you do community partnerships? Good. And is it a good experience? And how did you start? Was it somebody you already knew?
For me, the Media Rise is where the community partnerships have started. So by setting that space and time for people to come and have the conversation, we also invited community, but this was in DC, to do like, we did a 1-week festival, and 4 days were community events. So we invited key community stakeholders who are interested in promoting positive, inspiring media for social change to take ownership of some event, and we would be the co-sponsor. So 4 days we did events with community partners. The objective was not at that point to do research, but it's just to start a dialogue. And then the last 3 days we had panel discussions, and then we had a youth media festival, so which was led by community organizations. So there were youth and theatre group, youth and film making group, and youth and movement, creative movement group. So we got them together. So they were very excited to talk to one another. Because even though two of them were in the same building, but they had not talked to one another till we made that connection happen. So they were doing things independently. So now they know one another and their works, and have gone on to do things on their own because of the connections that we made. And one of them is visiting Singapore in a couple of weeks now, and she wants to talk to me about doing something here also.
Good.
So it's just that having
I think
relationships.
that, when you start these things, they have a life of their own.
Yeah.
I think it's a very cataclysmic, where kind of like it's a catalyst where you start something and it kind of spirals out. But I think you know, the follow-up is really important.
Mm-hmm.
One of the things I find that I'm not as good at is when I meet people, I need to kind of follow up with them, send a note and let them know I met them, and follow, set up additional meetings.
Yeah, so one of my co-founders is very good at that, and I'm learning that from him. He actually collects the visiting cards and has he keeps them all in, because only when you work closely with people, and there's so much wisdom to be learned from each person, how they work through. And so when he said, oh, media, he does work on oil, he's in the oil industry. He's so well networked with people, whichever topic you tell him, he can bring out 10 people from his connection. The thing is that it's not just the visiting cards, he always follows up with that person. and finds out what is it that person is passionate about and how he can help. And then over a period of time, that person will also become someone who helps you. So I'm learning, I'm not very good at it.
I'm not very good at that either. I wish I
learning
was.
that from him.
You know who's really
And
good at
cold
that?
calls also, we started making quite a few. What we would do is just, there's an organization, American Association for Media and Children. Obviously they will be interested in, we just call them and we say, we would like 15 minutes of your time to talk to you about this project. We'd like your advice on how we can shape this festival or this project. We want to take it worldwide. And then, you know, about 80% will not respond, but 20% reply back. And even if they can't help, they put us in touch with 4 or 5. So the ask that we make is often, can you put us in touch with a few others who would be interested in this? And they usually, that is an easy thing for them often, because we want the connections.
I think meetings are a really good idea for making those connections, because people already have self-selected to come to those meetings because they're interested. I did a project a couple years ago with the National Minority AIDS Council, where they put on an annual conference called the National AIDS Conference. It's a big conference, and they did one a couple years ago in San Francisco. And at that conference, they invited any participants who were interested in participating in a community liaison program to show up. And we got a group of about 20 people who came. They were all advocates from different parts of the country. And we explained the program that we wanted them to educate different groups about AIDS awareness and prevention, and encourage those people to do training as well. And then we had no money for them, but we would provide them with materials and training and support. And so ended up 17 out of the 20 followed up and agreed to do it. And we had started a national program based on that, and they became our community partners and connected with their social networks. And within about 6 months' time, we had generated about 800 national liaisons that were doing the similar training, and it just kept growing on a kind of a geometric level. But having those partners already there because of their interest in building a program was really critical. Luckily, I had my partners at the National Minority AIDS Council who were really good at maintaining connections with those people and communicating with them, because it is time consuming. Who are you going to say was really good at doing that?
You know who was really good was F. Rogers. He was the best at that, yeah.
He had that very convivial personality, really nice.
It was just so great. Sometimes it would make me laugh. You know, he would meet somebody, and then in the recess of his mind, there'd be some just obtuse connection, and he'd bring it out, and always